that's why this thing is in underlined thing, or this is a very much important thing which we are going to be in the discussion. Lockdown passed, we all of us faced the two waves of the lockdown in the 2020 and 2021. After first and second wave of the lockdown, there was a mere hike in the cases of anxiety disorder as well as the depressive disorder. Along with that, there were some other kind of complaints which occurred, which included sleep disorders, rise of multiple somatic complaints, anxiety related symptoms, lot of psychosis related cases, and the already existing or prevalent conditions of the psychotic illnesses went into the worst condition. There were a number of things were responsible to do or to make a hike of these kind of cases. And interestingly, there was a newly introduced cases which got into the more number of cases which we saw into the OPD basis. So that indicates that the importance of mental health. Also, we got to know some information or some news into the majority of a newspaper that there was an interesting fact that 30% hike in the distribution of medications related to the mental illnesses, which was observed during the COVID period and even after the end of both COVID waves. Ultimately, that indicates that there is increasing cases and increased seriousness of the mental health issues among the society. So that's why we must focus on the concept of the mental health and related illnesses and how to avoid it or how to deal with it. And of course, family physicians' role is very much crucial in it, because family physicians are the backbone of or the bond between the family members and the illness. So the family physicians can play a better role in understanding the signs and symptoms of onset before the onset of a mental illnesses, or the signs and symptoms related to the chronic or severe mental illnesses before it gets worse. And along with that, they know variety of, they are used to variety of factors, and they know everything about one single family to which they belong. So that it is a very essential or very much helpful for us to combine or to make and bridge between the family physician and the family. Yeah, in the recent past years, the face or the structure of whole health system was getting changed in the last few years. So that the need for corporate hospitals or multi-speciality hospitals and likewise online consultations, those things went on increasing. But in that, in this whole kind of a process, yeah, I know that I accept that this is the need and this is the future. But we as a society, we forgot one beautiful concept which were designed earlier by our ancestors, that is the need of family physician. In the early years, there were a concept of a family physician, so that they used to visit a place of a person, they used to communicate with the other family members, they used to participate into the rituals, functions, and all the events related to one particular family. And they had a healthy communication between amongst themselves. That's why there was always a possibility that family physicians, as early as possible, they get to know that if there is something related to health happens into the family, so that they were able to give an appropriate suggestions to the people or to the rest of the family members. But in last few years, it seems like that importance of the family physician was reducing slow by slow. Gradually it was reducing. But now, after the occurrence of COVID and ultimately due to the lockdown phase, and after that, the tremendous hike In the cases of anxiety, depression, and rest of the psychotic illnesses, it is the need that family physicians should get an important position into the family so that they communicate with them, and so that they can find out the earlier intervention to detect the cases which might get worse into the near future, and early intervention will be possible for a psychiatrist like us. So it is our duty also to bridge a communication between the family physicians, family members, so that we could get to know that what is the exact scenario of the disorder, what are the other hidden factors, and what are the contributing factors for development or for involvement of that kind of a disease, and what possible we can do for the benefits of the patient and for their family, so that they will come out of that illness related other issues, or that kind of a stigma, or that kind of a breakdown which happens in their life. So we have to first find out that a very simple strategy to find out what is exactly the mental illnesses. First of all, we have to understand the definition of a mental definition of a health, which includes the most important word is the mental well-being. We all know the definition of a health, that is health is a state of a physical, mental, and a social well-being, and not merely absence of a disease. So majority of us focuses on the physical health or the physical well-being person, and merely we ignore or we slightly get into ignorance of a mental well-being and a social well-being of a person. So that's why we have to focus on the mental well-being of the person. What is exactly the mental illness, or what exactly comes under mental illness? There are variety of illnesses which comes under the mental disorder. First one, the most commonly we found the patient. That is, if I see the 10 patients into the OPD, out of 10, 5 to 6 patients are belongs to the anxiety or depression. So that number is a very much high. So patient or any person most of the time faces this common kind of illnesses or mental problems like anxiety and depression. And rest of the 4 to 5 people in which the chronic mental illnesses are common, which includes schizophrenia or bipolar mood disorder or any other kind of illnesses. But majority of the patient suffers from anxiety, anxiety related disorders, depression, and depression associated with other psychological issues like somatic complaints or convergent traits, and likewise. So we have to understand that kind of things first. What is anxiety? In Marathi we call it as an अनामिक भीति, डर की भावना जिसको हम बोलते हैं. So this is what is anxiety, a fearfulness factor. Fearfulness without any reason or with presence of any triggering factors, that comes under the anxiety. What are the symptoms patient present to you with the anxiety features or anxiety disorder? I cannot label it as a disorder directly because it requires certain kind of a duration so that we could label it as a disorder. But first we have to see the common features which patient presents with and which comes to your OPD. That is the anxiety disorder or anxiety features. The first one is the fearfulness. That is the foremost and important thing. Second one is a persistent or occasional chest pain, that which happens mostly commonly. थर्ड वन इज द पल्पिटेशन, सीने में धड़कनें तेज हो रही है या फिर धक धक होने लगा है, ऐसा लगता है कि कुछ हो जाएगा मुझे. दैट इज व्हाट इज इन पल्पिटेशन. along with that some patients comes to you with an abdominal discomfort, मतलब पेट में ऐसे कुछ हो रहा है जैसे लगता है, ऐसे लगता है कि घबराहट हो रही है, मतलब पेट में से गड्ढा सा गिर गया ऐसे ऐसे लग रहा है, या फिर लूज मोशंस टाइप फीलिंग, जैसे कि परफॉर्मेंस एंजाइटी के वक्त अक्सर बच्चों को होती है. Likewise the symptoms whenever if anybody has to face exams, anybody has to crack an interview, anybody has to give a performance on stage, or anybody has to do or achieve some kind of a major task, before beginning or initiation of that kind of activity, person
ठीक लग रहा है,
similar to it.
लग रहा है.
Okay, so these symptoms occurs commonly into the patients. Fearfulness, chest pain, palpitation, and foremost common is abdominal discomfort. So these are the common symptoms. Apart from that, breathlessness or breathing difficulty. Majority of the patients suffers from breathing difficulty. It ultimately affects on their sleep cycle. Some patients comes to you with a complaint of typically presence of fearfulness in the night. डॉक्टर साहब मुझे जब मैं रात को सोने जाता हूँ तो पता पता नहीं क्यों ऐसा होता है कि मुझे अचानक से घबराहट होने लगती है, अचानक से मतलब डर की भावना पैदा हो जाती है, ऐसा लगता है कि मुझे कुछ हो जाएगा या फिर मुझे अंधेरे से डर लगने लगता है सोने के टाइम। ये चिंता या फिर इस तरह की भावना बहुत ज्यादा दिमाग में आती है। दिस इज व्हाट वी कॉल्ड एज एन fearfulness. This is a type of anxiety. So some patient presents to you with the symptoms that anxiety happens during specifically in the night. बाकी दिन के वक्त सब ठीक रहता है, लेकिन रात को जब सोने जाता हूं तब दिक्कत आ जाती है। Along with that, some patients have an fearfulness about the closer atmosphere or as a being alone, अकेले रहने में उनको डर लगता है या फिर क्लोज एनवायरनमेंट में उनको डर लगने लगता है। So this kind of anxiety features comes to you with a different kind of a presentations, and that ultimately impacts or affects on their sleep cycle. That's why patient gets disturbed. There are variations in the sleep cycle disturbances also. The first one thing which happens is that I don't get peaceful sleep during the 6 to 8 hours of a duration. I wakes up in between. I get delayed onset of sleep. जब भी मैं सोने जाता हूँ या फिर सोने जाती हूँ, बेड पे लेटने के बाद मुझे नींद जल्दी नहीं आती, बहुत देर से आती है। तकरीबन अगर मैं 11 बजे सोने जाऊं या फिर 12 बजे सोने जाऊं तो मुझे नींद लगती है 1:30, 2 या फिर 2:30, 3 बजे, और फिर सुबह में मेरे ड्यूरेशन के साथ उठ जाती हूँ 6 या 7 बजे तक, लेकिन उसके बाद मुझे फ्रेश नहीं लगता। दैट हैपेंस। किसी किसी को ये होता है कि नींद 10-11 बजे लग जाएगी, लेकिन मैं 1:30 या 2 बजे उठ के बैठ जाता हूँ, उसके बाद मुझे नींद नहीं आती। Some people comes with the complaint of they intermittently wakes up in between the sleep cycle. डॉक्टर साहब, रात्री जेव्हा झोपतो त्यावेळेला मोस्टली मला असं होतं की मध्ये मध्ये मला जाग येते आणि त्याच्यानंतर पुन्हा झोप लागायला त्रास होतो, लवकर झोप लागत नाही, त्याच्यानंतर पुन्हा 1-1.5-2 तासाची झोप लागते, पुन्हा परत जाग येते. And it keeps on happening throughout their sleep duration, so that ultimately it reflects on their daily routine or their daily activities. Patient don't feel fresh, and sometimes comes with a complaint of that they sleep at their regular time interval, they sleep regularly or on their time, they get enough sleep but they wakes up early in the morning, they don't feel fresh. So these are a variety of sleep cycle disturbances which we don't observe easily. अगर हमें ऐसा लगता है कि हम हाँ मुझे नींद नहीं आती, फिर नींद का प्रॉब्लम है, तो we come into the conclusion that the patient might having the insomnia or the patient having the disturbed sleep cycle that one, and we write the medications for the same, and then we send it patient back to their home. But we have to understand that sleep is merely as a symptom, it is not a disorder. This mistake which we have to correct it. Sleeplessness or disturbed sleep is not a disorder. It is a symptom which ultimately comes out of the result because of the mental problems, because of the psychological issues. So we have to ask the patient first, yes, if you have a sleep disturbances, that's okay. Whatever may be the kind of a pattern. Apart from that, where our role starts. Apart from that, any other thing is bothering to you, any other problems happening to your family, what is your mood or how is your mood in the daytime, how is your work schedule, that we have to ask, so that we will get not this is not expected from all of the consultant that they should go entirely like a psychiatrist and go into the deeper version, but at least some of the questions will necessarily or will definitely put and some information to your mind, that is sleep because of some other factors his or her sleep is getting disturbed. So these other factors which we have to rule out, because of the depressive features, because of the schizophrenia related symptoms, because of the mania, or because of the anxiety features. Patient don't get enough sleep. So first we have to understand that sleep is a merely a symptom which comes as an outcome of these all kind of psychological issues or psychological problems. Along with that, the second most important thing is about the appetite. In our examination during our MBBS curriculum and even after that, when we do the clinical examination of a patient, we observe or we write about patient's consciousness, orientation, and cooperation, all those things. Along with that general condition, then we check vitals. Apart from that, we also ask them about sleep and their appetite. How's their appetite? Are they getting enough food, or are they getting enough? They are getting much or enough hungry. Is that related to their illness? Yes, absolutely. Majority of cases related to the anxiety, depression, and other forms of the psychological disorder, they reflects into the sleep cycle and food cycle. That is their food appetite. Appetite get reduced or appetite get increased. Both are related to the depression as well as anxiety. So that thing which we have to ask is about sleep, and along with that, appetite cycle. So this is also an important thing. This is what I was talking about, the anxiety features. There are some of these symptoms which are related to the anxiety. Apart from that, there is a depressive features. I share one slide presentation with you about the features. Are you able to see or not yet?
No, sir.
Wait. Are you able to see now?
Yes.
Yeah. So this is what I'm talking about, the depressive features. So हमें ये जानना बहुत जरूरी है कि लोकल डिस्क्रिप्शन क्या है डिप्रेशन का. हर आदमी आपके पास आते वक्त इस तरह के फीचर्स लेके नहीं आएगा कि मुझे डिप्रेशन है. Majority of the people don't understand what is exact concept of the depression. Sometimes patient feel nervous about anything. They feel like a dysphoric or small occasion or a short period of low mood features. But we can't tag them as a core symptoms of the depression. So we have to understand the local terms or names for the depression. What exactly happens with the patient undergoing the depression? We have to rule out those things first. This feature, if there is any presence of the features of a low mood, there is a lack of interest into the activity, feels like a reduced energy level. लोग बहुत बार आते हैं कि मुझे कुछ काम करने की इच्छा नहीं होती, मन नहीं होता, मेरा काम में दिल नहीं लगता है, ऐसा लगता है कि पूरी एनर्जी खत्म हो चुकी है. या फिर उनके रिलेटिव्स आपको आके बोलेंगे कि ये दिन भर सोता रहता है या फिर रात भर जगते रहता है, लेकिन इसका स्लीप साइकिल डिस्टर्ब है. दिन भर सोता नहीं है, उसको नींद नहीं लगती, लेकिन पड़ा हुआ रहता है, कुछ करने की इच्छा नहीं होती, बाहर जाने की इच्छा नहीं होती, ऐसा लगता है कि ठीक है यही बैठा रहूं, यही ऐसा करता हूं. तो दिस काइंड ऑफ symptoms presents to you with underlying the this kind of a diagnosis of a depression. So we have to understand that what are the local terms or names for the depression. Second one is how the people with the depression treated and perceived by the local community. This is which we have to understand, because you have through and through communication with the patient, along with that their family members, and you know the tendency of the community or the society people which are living around you. So that we have to understand that what comes under this kind of description related to the depression. उन लोगों के साथ कैसे बर्ताव किया, likewise, और ट्रीटमेंट उनकी किस तरह से की जा रही है विथ रिगार्डिंग टू द सोसाइटी. लोग किस तरह से इस चीज को देखते हैं, उसे हमें देखना थोड़ा सा जरूरी है, बिकॉज वी गेट इनफ नंबर ऑफ इनपुट्स फ्रॉम दिस काइंड ऑफ अ डिस्क्रिप्शन. अगर पेशेंट जेन्युइनली इन द डिप्रेसिव स्टेट है तो लैक ऑफ मोटिवेशन, लैक ऑफ इनिशिएशन इन एक्टिविटी, रिड्यूस सोशल इंटरेक्शन, लोगों से ज्यादा बात नहीं करता, ज्यादा घुलता मिलता नहीं है, अपने ही कमरे में बैठा हुआ रहता है. वहां जाके आप उसको मोटिवेशनल स्पीच नहीं दे सकते, या फिर उसको जगाने के लिए कि उठो जागो, या फिर स्वामी विवेकानंद जी के जैसा हम उसे इस तरह से मोटिवेट नहीं कर सकते. यस, देयर आर स्ट्रेटेजीज बट इन द डिफरेंट वेज. So first we have to understand how the society or how the community around you sees the patient. वो लोग किस तरह से पेशेंट को देखते हैं, ये हमारे साथ घुलता मिलता है क्या? जो भी सोसाइटल प्रोग्राम्स होते हैं, जो भी त्योहार का टाइम होता है, वहां पे उसका इंटरेक्शन कैसा रहता है? Does he involves in that kind of activity, or in that kind of activities also, that kind of events also, he keeps himself isolated, withdrawn from the society? That we have to understand, and that we get the information from the rest of the members or the society members. If you have that kind of good communication among the family members as well as the people living into the society, then definitely you will give an enough idea that what exactly person is going through. So local description of a depression is very much important. Let's come to the another slide, that is core symptoms of a depression. So as the mentioned here, that is a persistent depressed mood. So there is a pattern of the depressive features that usually on each day patient presents with the similar kind of symptoms. It doesn't happen like आज मुझे ठीक नहीं लग रहा है, लेकिन कल जो था बहुत फ्रेश था, अच्छा था, परसों भी बिल्कुल ठीक नहीं रहता. No, the depressive cases doesn't go likewise. They have a persistent mood or persistent dysphoria happens in them. And you will get to know easily that कि बहुत पिछले कुछ दिनों से the exact duration you will get to know about it. आप उनके घर वालों से पूछ सकते हो. You can ask their family members, parents, that since how many days it is happening, and they definitely will tell you since past 2 months or 3 months, since past 6 months, or since year. So you will get a definite idea about the core symptoms of a depression. And second one, which I said earlier, that is diminished interest or pleasure from the activities. कुछ करने की इच्छा नहीं होती, कितना भी कुछ अच्छा हो या फिर उनके इंटरेस्ट से रिलेटेड, उनकी दिलचस्पी जहां पे है उससे रिलेटेड कोई वाकया हो, या फिर उससे रिलेटेड कोई प्रोग्राम हो, उससे रिलेटेड कोई हॉबी हो, खाना हो, मनपसंद खाना हो, या फिर मनपसंद जगह पे घूमना जाना हो, इन सारी चीजों से जिसको हम बोलते हैं कि मन उब गया है, उस तरह के सिम्टम्स डिप्रेशन के केसेस में देखा जाना बहुत ही लाजमी है. Coming to the next slide, you can see there are common presentations of a depression. Not necessary कि all the symptoms will come under a single patient, but majority 3 to 4 symptoms of this all kind of a common presentation will definitely come under the patient who is undergoing the depressive phases. That is persistent symptom or physical symptoms with no clear cause. Joint pain हो रहा है, persistent headache हो रहा है. These are the very much common symptoms. आप लोगों के पास ये बहुत सारे symptoms लेके patients आते होंगे कि उनमें से कई patients के बारे में आपको ऐसा लगता होगा कि I am not getting an enough clue. Even after doing the necessary investigations like routine blood investigation or like up to the higher investigations like CT scan, MRI, X-rays, whatever may be. If all these reports are coming normal, then we have to look at some psychological aspect where our role starts. Is there non-specific physical complaints? मतलब एक ही इंसान में हेडेक हो रहा है, persistent headache, सर दर्द बहुत हो रहा है, joint pains हो रहे हैं, बदन दर्द होता है, बॉडी एक होता है. अगर आप उनसे पूछेंगे कि बॉडी एक होता कहाँ पे है, तो आज अगर आपसे पेशेंट मिलने आया तो वो बोलेंगे कि बैक हो रहा है. 2-3 दिनों के बाद अगर आप उनको फॉलोअप के लिए बुलाते हो, फिर आफ्टर 5 to 7 डेज आप उनको फॉलोअप के लिए बुलाते हो, तो बोलेंगे कि बैक एक नहीं हो रहा है, लेकिन अभी चेस्ट पेन हुए जैसा लगता है, या फिर अभी मेरा हाथ यहाँ से थोड़ा सा टिंगलिंग सेंसेशन आया जैसा लगता है, या फिर मेरे जोड़ों में दर्द हो रहा है, कमर में दर्द हो रहा है. So these symptoms or these painful situations keeps on shifting from one place to one body part to another body part. So multiple persistent physical symptoms, or some patient comes with this all kind of symptoms together and they don't find any exact cause behind it. So this multiple persistent physical symptoms with no any clear cause we find out. Second one is the low energy. Low energy, that is I feel like I'm dehydrated or hypoglycemic, so that I don't feel energized or fresh to do any kind of activities, always feels low, always feels fatigue. So these kind of symptoms also common into the depression. Along with that, as I said earlier, that is sleep problems, sleeping too much or sleeping too little. Sleeping too much is also related to the depressive features. Along with that, sleeping less is also related to the depressive features. So in both cases, we cannot ignore the fact that there might be a case of a depression. Same applies to the appetite. If person eats more, it is also one of the important factor which includes under depression. And if a person eats less, it is also comes under the case of the depression. It might come under the depression. So these are the two basic interesting factors. That is sleep problem, sleeping too much or sleeping too less, eating too much or eating too less. Along with that, some patient comes with the combined symptoms like an anxiety as well as depression. Next one is the change in the appetite as well as weight, either weight loss, either weight gain, because of the either increased appetite or reduced appetite. Along with that, belief of a worthlessness. Worthlessness means there is no point in living in this society, no point in living in this world. जीने की तमन्ना नहीं है या फिर मुझे कुछ करना नहीं है, करके क्या फायदा, अगर मैं पैसा कमाऊं तो उससे भी क्या फायदा, पढ़ाई करूंगा तो उससे भी क्या फायदा होगा, कुछ मतलब नहीं है, ये करके क्या करना है, शादी करनी है, शादी करने के बाद झगड़े हो जाएंगे, झगड़े होने के बाद फिर तलाक हो जाएगा, तलाक होने के बाद फिर अकेले रहना पड़ेगा, फिर इतना सारा पैसा कमाने से क्या फायदा, एंड देन अगेन फीलिंग ऑफ अ वर्थलेसनेस, एंड दिस साइकिल कीप्स ऑन कंटिन्यूइंग. सो दिस इज बिलीफ ऑफ अ वर्थलेसनेस. एक बार एक पेशेंट once one patient came to the OPD and he was that kind of a worthlessness. मैं कुछ भी उसे solutions बताने की कोशिश करूं उसके symptoms से related to the counseling, he had every time a simple solution for that. ये सब करके भी क्या फायदा होगा, ये सब करने के बाद भी मुझे क्या हासिल होगा, पैसा तो है, पापा का ही है, अगर मैं उससे ज्यादा भी कमाऊंगा तो फायदा ही क्या होगा, खाना पीना सब खाऊंगा लेकिन एक दिन तो मुझे मरना ही है. Means all those things were starting from the earning money or living wealthy and all those things, and ultimately it was coming to the end, that is the death of a person. So that person had a feeling of a persistent worthlessness. ये सब करने का क्या फायदा, कुछ फायदा नहीं, जीने का क्या फायदा, कोई फायदा नहीं, पैसा कमाने का क्या फायदा, कुछ फायदा नहीं, क्योंकि आखिर में एक बार मरना ही है. That sometimes patients having excessive guilt. Excessive guilt has a different kind of a shapes. Guilt about not nourishing or not well educating the children, guilt about not taking enough care of the parents, guilt about being in the relationship or being not in the relationship, guilt about if a person did something against the law or something illegal, the guilt about it, or guilt about hiding some things, or guilt about anything. So this is a feeling of a guilt. Majority of the time guilt happens into the cases related to the extramarital affairs or extramarital relationships as well. Not taking care of a parents into their old time after death of the parents. So these kind of a guilt happens into the cases of the depression. Sometimes a patient having डेथ ऑफ लव्ड वन, अगर कोई नजदीक का या फिर रिश्तेदारी में या फिर घर में अगर किसी हमारे नजदीकी इंसान की या फिर प्यार मोहब्बत से रहने वाले किसी अगर इंसान की मौत होती है, वो चाहे उनके फादर हो या फिर मदर हो, तो उसके बाद एक तरह का पोस्ट ट्रॉमेटिक स्ट्रेस होता है, पोस्ट ट्रॉमेटिक ग्रीफ आने लगती है, एंड ग्रीफ फॉलोड बाय गिल्ट. उस टाइम पे उस तरह की गिल्ट डेवलप हो जाती है. देयर आर हायर चांसेस दैट गिल्ट मे परसिस्ट for more than 1 to 2 months, more than 3 months, more than 6 months, and keeps on continuing, and it causes a development of a depressive features. Another one important thing is that indecisiveness. मला काय करायचं हे कळत नाही, घरातले डिसिजन्स घेता येत नाही, किंवा कुठलाही निर्णय घ्यायचा तर माझा गोंधळ उडतो, समजत नाही मला काय करावं. त्यामुळे घरातले मला मापात काढतात किंवा माझी चेष्टा करतात की इतक्या छोट्या छोट्या गोष्टींमध्ये देखील मला निर्णय कसा घेता येत नाही. म्हणजे जेवण बनवायचं तर मग मी चपाती बनवू की भाकरी बनवू, भाजी बनवायची की नाही बनवायची, भात लावायचा की नाही लावायचा, यासारख्या छोट्या छोट्या निर्णय घेण्यामध्ये देखील माझा गोंधळ उडतो किंवा मला निर्णय घेता येत नाही. So that kind of indecisiveness comes into the patient very frequently. I observed this kind of indecisiveness in the growing youngsters while taking a decision making tendency get reduced during their college time or during their academic progress. And I also observed this kind of indecisiveness into the housewives. After there are a number of factors responsible for it. I will not go into the details of it because this is a separate part of a discussion. But I commonly observe this kind of indecisiveness factor in these kind of groups. Secondly, the restlessness or agitative factors. Not getting well, मला बरं वाटत नाहीये किंवा मला ठीक वाटत नाही, त्याच्यामुळे येणारा जो गिल्ट, त्याच्यामुळे असणारा जे रेस्टलेस आहे किंवा एजिटेशन आहे, त्याच्यातून निर्माण होणारी इरिटेबिलिटी. See, one thing which we have to understand, if a patient comes to you with a complaint of irritability, hold on, thamba, रुकिए. We have to go into the slight depth of that irritability. Irritability doesn't related, not always relatable to the manic features or not always related to the psychotic disorder or psychosis. Majority of a time irritability comes under the symptoms of anxiety also, and also the comes under the symptoms of depression also. So we have to find out, is this irritability is related to the psychotic features, mania, or it is related to the depression or anxiety. This is a very tricky situation. You can take a help of the any expertise or the psychiatrist like us, that is a patient is having or showing the symptoms related to the irritability. There are some patients comes to you with the symptoms like breaking things or throwing objects or using fear, getting parents or verbally towards their life partners. So this kind of irritability, or gets quickly irritable on small aspects, on small issues, if things not getting done in their way. That's how the irritability occurs. So irritability has a number of shades into the psychological disorder. Irritability comes under schizophrenia. Irritability comes under the psychotic disorder or psychosis. Irritability comes under the bipolar mania. Irritability comes under depression, and irritability comes under anxiety. Along with that, irritability also comes under the personality traits or personality disorder. So be careful while judging the irritability, because this kind of a shades happens into the irritability and agitation. Along with that, the second one thing is the feeling of a hopelessness, which we all know the word explains itself. And last one and important is the suicidal thought and acts. This is also an important thing. I sincerely saying to all the consultants or all the physicians, be careful or be alert about the suicidal thoughts and acts if you see in any of your patients, because this is an psychiatric emergency. Like any other road traffic accident, like any kind of a myocardial infarction, like any kind of a cardiac comorbid conditions, like any other serious illnesses, it is similar to that kind of a serious issues or that kind of emergencies. So if a patient is having suicidal thoughts, ideations, or if the patient has done this kind of act in a smaller way also, do not neglect it. Take it into very seriously and inform the psychiatrist along with, or refer the patient to the psychiatrist, because this is a very important situation. Along with that, in your jurisdiction, you can do one thing, that asking the relatives to keep an eye on the patient. Secondly, keeping sharp objects away from the patients, keep monitoring on the every move of the patient till the patient gets enough medical help or enough psychiatric help. These things you can do for the patients to avoid any kind of a suicidal thoughts or the ideations, because it's a very very serious issue. Sometimes interestingly, बहुत सारे लोग आपके पास, आप अगर suicidal ideations या फिर thoughts के बारे में पूछोगे, so surprisingly some of the patients have a clear cut idea how to die or how to do a suicidal attempt. अगर आप उनसे पूछेंगे तो उनके पास जवाब रहेगा. कुछ पेशेंट्स ऐसा रहते हैं कि आपको किस तरह से मरना है इसके बारे में आपके दिमाग में क्या ख्याल आहे किंवा कसं मरावं याच्याबद्दल तुमच्या काही आयडियाज आहेत? असं जेव्हा तुम्ही पेशंट्सना विचारता त्यावेळेला पेशंट्स काहीही स्पष्टपणे सांगतात की मला पंख्याला लटकून जीव द्यावासा वाटतो किंवा मला टेरेसवरून उडी टाकून जीव द्यावासा वाटतो, या फिर कुछ पेशेंट्स ऐसा आपको बोलेंगे कि मुझे जो स्लीपिंग पिल्स वो लोग जो बोलते हैं वो लेके मुझे खाने का दिल करता है, या फिर पेस्टिसाइड्स या फिर घर में फिनाइल पीने का दिल करता है. So these situations are extremely comes under the emergency scenario. We have to be a very alert in keeping in that mind that patient will definitely do an attempt which patient is expressing his word with कि इस तरह से अगर करना है तो definitely patient ऐसा ही करेगा because we have the evidences related to it. Patients लोग इस तरह से करते हैं. So we cannot ignore the fact about the suicidal thoughts and acts related to it. Comes into the next slide, that is the contributing factors for that. These are the biological, social and psychological, as we all know. So these are the other related or detailed factors related to the it. So this slide is a very important slide. Average prevalence of a depression in a patient with the physical diseases. The disease list which is given here in the slide, you deal with those kind of a patients every day. The patients having the tuberculosis, patients having the HIV/AIDS, patients who is suffering from the cancer, patients having the known case of a hypertension or a diabetes, and a patient who is having the myocardial infarction. This also applies for the anxiety case also. So presence of a depression in these kind of a comorbid conditions is very common. Along with that, presence of anxiety features also very much common in these kind of pre-existing comorbid conditions. So we have to keep it in mind कि हमें पेशेंट्स को हम if we write a prescription for the patient, अगर हम पेशेंट के लिए दवाइयाँ लिख के देते हैं या फिर उन्हें बोलते हैं कि इतने दिनों के लिए लेनी पड़ेगी, take it into example of the patient who is suffering from the hypertension or patient is having a diabetes. We know that patient has to take this medication for a longer period of a time. But sorry, saying the thing that you have to take a medication for a prolonged period of a time and accepting the thing that I have to take a medication for a prolonged period of a time, both the psychologies are very much different. We have to keep it in mind always. As a role of a doctor, whatever we say is on the behalf of the patient or in their well-being of the patient. This is our role. I can truly understand, but we have to understand the psychology of a patient as well. जिंदगी भर दवाई खाना किसे अच्छा लगता है? किसी को भी अच्छा नहीं लगता. जिंदगी भर किसी तरह के अगर प्रिकॉशंस लेने हैं, डाइट फॉलो करना है या फिर उस तरह के रिस्ट्रिक्टेड एनवायरनमेंट में अगर जीना है, उनको लाइफ रिलेटेड या फिर हेल्थ रिलेटेड कुछ रिस्ट्रिक्शंस फॉलो करने हैं, we of course know, I surely agree with all of you that they have to follow these kind of conditions, they have to follow these kind of rules for their well-being. But as considering the psychology of a patient, sometimes they feel frustrated. They feel frustrated. Even sometimes they feel agitated. They express their anger, they express their frustration, they express their irritability towards their family member. Of course, due to the social norms, they do not express their anger or irritability towards you. That कितने दिनों तक डॉक्टर साहब ये दवाई लेनी पड़ेगी, आप मुझे बोल रहे हैं कि सालों साल लेनी पड़ेगी, ये कोई तरीका होता है क्या ऐसा? Of course, they will not express to you with these kind of psychological issues or these kind of emotions, but they will present in front of their family members. Family members will surely tell you that is कि ये काफी बार गुस्सा होते हैं कि दवाई लेनी पड़ती है, खानी पड़ती है, एक दो बार मिस भी होती है, हम उन्हें बहुत बार कहते हैं, समझाते हैं. Yeah, we understand that you are doing it on the behalf of the patient for their well-being, but understand the psychology of the patients as well. कि नहीं उन्हें पसंद आ रहा है क्योंकि बहुत ज्यादा वो परेशान हो रहे हैं कि उन्हें त्यांना कंटाळा येतो या गोष्टीचा की किती औषधं खायची. We have to understand that psychology first. And continuous and persistent counseling whenever this kind of a situation will come in their life and they present with this kind of symptoms in front of you, or if their family members briefs you about their symptoms or their irritability issues related to the taking medication, having the related to the antihypertensives, anti-diabetics, medications related to the thyroids. So if the patient presents with these kind of symptoms, we have to understand that patient might develop these kind of a psychological imbalances. We cannot label it as a disorder immediately, but they might develop these kind of a symptoms. They might develop these kind of a depressive features, anxiety features. We have to understand that. If we understand that, it will be easier for us to counsel them. Sometimes, apart from the medication, what is necessary factor is that the counseling of the patient. Because meanwhile, if the treatment pattern is for prolonged duration, meanwhile, you have to take an update from the patient. You have to interact with the patient. No doubt, we know that the sugar is under control. If we know that, yes, the blood pressure is under control, everything is under control, patient is taking medications, patient is having the good physical health, even after that also, we have to tell the patients, or we have to communicate with them with any kind of a topic, just a normal chit chat or just normal conversation apart from their medical illnesses. That will surely boost their confidence, that will surely encourage them, and that will surely tell them that okay, these good things are also happening in my life. Show them the good side of their life, show them the other good things are happening with their life apart from this medication or apart from this chronic illnesses. Chronic illness, make them realize that these kind of illnesses, the patient who is having the tuberculosis, HIV, cancer, hypertension, diabetes, and lot of, though they have these kind of illnesses, but that is one part of their illness, and the rest of the part, if anything good is happening, show it to them. So this is a kind of a counseling skill, or that communication skill that the family physicians does have. And if not, then we can improvise accordingly and show that the good bridge will develop in between the family physician, in between the physicians and their patients. So these are the all related to the all detail talks about it. I will not go into the details of it because of the time limitation. I will come to the another important point related to the so what is exactly a great advantage of being a family physician? So first and foremost is the beautiful thing that there is no as such language barrier. Most of the time, family physician is taught for which the patient or family members. So this is a very beautiful thing. Language is the major communication tool in establishing a conversation or establishing a relationship among the persons. So the language barrier is not there the majority of the cases. So this is a plus point of being a family physician. Second one, family physicians can take frequent follow-up with the patients and their family members, because they used to go frequently, or they used to communicate with the family members and patient. So frequent follow-up is possible in this case related to the mental health or related to the mental illnesses. Along with that, the most of the time what happens, if a person or if any doctor is being a specialist in any branch or in any field, then their focus become disease centric. Most of the time it happens because they check the patient with the disease centric approach, which is not wrong, but along with that, family this thing differs family physician from doing this kind of activity, because a family physician's approach towards patient is a person centric. So they have a more interactive or communicative approach with the persons rather than any kind of a specialist, because patient with any kind of illnesses will come to the specialist only if there is a requirement. Otherwise, we don't used to go to the specialist very frequently for small things or for a small kind of a complaints. They used to go their family physicians first. They used to take advice of them. They used to tell everything related to it or everything also not related to it to their family physicians. So but this is we call as a person-centric approach. It is a very helpful in diagnosing and in treating the cases related to the mental disorder. Because mental illness is not just a merely diagnosing a disorder and treating it, but also taking a regular follow-up is essential into the cases of the mental illnesses. Along with that, patient's rehabilitation is the second most important thing into the cases considering the mental disorder. So for that, we need important or supportive family, along with that supportive community environment, along with that social awareness related to it, and communication among this all kind of a structure or all kind of a societal system. And family physicians plays this a very huge role in it, as their approach is like a person related approach or person to person approach. Apart from that, there is other condition that family physician knows about their family very well. They knows everything about patient, everything about the family up to majority of extent, which specialist doesn't usually know, or they have to find out by the brief history taking or all those things. But if things keep on changing into the family, not each day is the same day like a previous old day. Each day things keeps on changing. Each day new things comes into the family. Old things goes on disappearing, or new relationship establishes, new decision making, or old decision revisions or erasing those decisions. So these kind of a changes happens into the one single family. Family physicians are generally aware of those conditions, and these changing atmosphere, taking the financial decisions, health related issues, physical ability of the patient and their family members, decision making related to the any kind of scenario, establishing the relationship, marriages, celebrating the festivals, academic growth, if there are any kind of children into the family, their growth, their approach towards any kind of issue, their interest, the patient's interest and the family members' interest, interpersonal relationship among the family members also. These all things are very much new for very much aware for the family physician, or family members are very much aware of these all kind of conditions, so that considering all these kind of points which comes under the family, or which are directly or indirectly related to the one patient, so that we can find out the supportive measurements required for the well recovery of the patient suffering from the mental illnesses by considering these all kind of factors. And hence family physician plays a crucial role into the patient's mental health or their well-being. So I must insist the other psychiatrists also, and the majority of a psychiatrists take that step also, that is communicating with the family physicians. That is a very much essential or required. And as a family physician, you must remember that if patient needs any kind of a mental illness related health or any kind of emergency related health, you must suggest any kind of a psychiatrist nearby to you or nearby to the patient's family or patient's relative. And so that if the patient, if the family brings that patient to the psychiatrist, so make sure that if communication should get happen between you and the psychiatrist, so that you will able to inform them about some important factors or your perspective about the family, about the patient, so that helping the patient and treating the positive factors will be helpful for the psychiatrist also, and it ultimately benefits to the family of the patient and directly to the patient as well. Because in many cases we see the patient is having the disturbed family background. I saw two cases where the 14-year-old one girl, and in another one case that is 16-year-old guy, both were having the problem. They were getting physically abusive, verbally abusive towards their mother and parent. The girl was having grudge towards her mother. She was thinking that the mother is a villain, as this was the mother's point of view. And in another one cases which I just recently saw, that the son was having grudge towards his father, and he was thinking that father is the main villain. And then I kept on discussing things with them separately. I discussed with the mother first, then I discussed with that girl first, separately in the separate environment with the absence of the other family members. Then I got to know that each one of them has their own personality issues. This is very interesting. They had their own personality issues, and no one were ready to compromise, or no one were ready to adjust with each others or with other members. And they were continuously thinking like मेरी गलती नहीं, उनकी गलती है, उनको ट्रीटमेंट की जरूरत है. गर्ल वाज सेइंग कि मुझे क्यों पागल बनाओ, ट्रीटमेंट आप दो. that की ट्रीटमेंट की जरूरत मुझे नहीं है, मेरे फादर को, because he was he used to be a verbally abusive, physically abusive towards his mother as well as his children. So the behavioral mechanism reflects into the children. अगर ये केस अगर न्यूट्रल लेवल पे हम हैंडल करने जाते हैं तो डेफिनेटली बाय सीइंग ऑल काइंड ऑफ दोस काइंड ऑफ सिम्टम्स विद एंगर, इरिटेबिलिटी इश्यूज, impulsiveness, reduced need for sleep, so we can directly will come to the conclusion that this is a behavioral disturbances, or this is a kind of mood congruent behavioral disorders. But no, we have to hold on before passing end of a judgment, or before thinking that if any person is having a psychological issues, find out the stressor related to it, find out the triggering factor related to it, and find out any familial environment responsible for it. In both cases, the treatment or the counseling was necessary for their parents or their guardians, and not for the children. The behavior of children were merely as an reflection of their parents' behavior. So ये केसेस में हम लोगों ने उनके साथ डिस्कस किया, पेरेंट्स को इन्हें कन्विंस किया कि ट्रीटमेंट से ज्यादा हमें काउंसलिंग की तरफ ध्यान देना चाहिए, ताकि उन लोगों को भी ये रियलाइजेशन हो कि कहीं ना कहीं हमारी भी रूटीन या फिर डेली कम्युनिकेशन के टाइम पे या फिर फैमिली इन्वॉल्वमेंट में हम जब टाइम स्पेंड करते हैं, तब हमारी भी कहीं ना कहीं मेजर कंट्रीब्यूशन है इन चीजों को बिगड़ने, चीजों को बदलने में. अगर उसे हम अच्छे से समझ पाए, अंडरस्टैंड कर पाए, अपने आप में बदल कर चेंजेस ला पाए, तो चीजें काफी हद तक वो सुधार सकती है या फिर इम्प्रूव हो सकती है. एज अ फैमिली फिजिशियन, व्हाट यू कैन डू, you can just discuss with the all family members and the person is having the psychological issues separately, so that you will get to know and better idea about each person's point of view towards others, and then hopefully you will get to know the exact scenario, what is happening to the patient, and what is the perspective of their family members towards patient illness. This is a very interesting information you will get into. So as a family physician, what comes into the cycle is that identifying the problem. Along with that, after identifying the problem, once you identify the problem is the patient is having the anxiety and depression, psychiatric disorders, first the one thing which I wanted to tell you that this is a very time limited or time bound program or lecture series for all of us, so that I was concentrating or focusing on the major issues which we see into the society or in the OPD scenario. That is, one is the anxiety and the depression. Rest all other factors we can discuss this later on, but that also we are used to it, or we see in the daily routine, that is the psychotic features, that using verbally abusive or physically abusive patient, decreased need for sleep, and lot of things related to schizophrenia and bipolar disorder. But anxiety and depression, why I was focusing on that, because these are the very much common scenarios which are getting up heavily after the COVID breakdown. So if we understand that yes, these are the psychological factors or these are the psychological problems, then we have to identify if any of this problem is present into the patient. If once we find out that yes, there is a problem, yes, there is an issue, assess that problem. What is exactly the problem? What are the symptoms of that problem? When these symptoms get triggered out or get increased, or what triggers it the most. This is, we have to assess the thing. What are the positive agents for that? What are the positive factors? If family atmosphere is responsible for that, because changing lifestyle is also an additive factor for developing these kind of psychological issues in these days. Demand for the money, for lavish or living a comfortable lifestyle, people earns more money or try to earn more money. That's why they compromise their physical as well as mental health, compromise their own ability, increasing the addiction issues into the patient as well as into the routinely life. Social drinking is also a most positive factor in developing these kind of anxiety as well as depressive features, because alcohol induced depression, alcohol induced anxiety disorder, alcohol induced sleep disorder, these three things are very much common. Alcohol induced psychosis is also common. Alcohol induced mania is also common. I'm taking only an example of the alcohol, but apart from alcohol, other positive factors like cannabis, like other drugs, these are also a contributing factor for developing these kind of psychological issues. So we have to understand, or we have to rule out if there is a causative factor like an substance dependence. If there, if patient is having any kind of physical comorbidity which is playing a key role, that I was saying about it, that if patient is having the hypertension or diabetes or likewise the disorder, if patient is having any chronic illnesses which is contributing to the development of a depressive features, you have to rule out it first. Okay, so these are the things. Any operative procedure has been done before or in between, or is planned for in the next future or in coming days, and that triggers the patient most, so that anxiety is developing in with the patient, sleep disturbance develops because of that. So these are contributing factors we have to rule out. This is the assessment of the problem. After assessing the problem, after finding the causative factors of the problem, we will come to the possible solutions of the problem. Not for each psychological issues और किसी भी तरह के psychological problems के लिए हमारे पास अलग अलग से छोटे छोटे solutions होने चाहिए. Possible solutions क्या हो सकते हैं? एक ही solution निकाल के अगर हम वर्कअप उस पर नहीं हुआ इन किसी भी वजह से, then we will feel confused or what we will do next. This type of scenario will come to us. So we have to make out the possible solutions. If this kind of a solution fails, okay, it's not an issue. We will shift to the next kind of a solution. If this works, it's all good. We will keep on going. If not, it's okay. We will come to the next point of solution. If not, any other kind of a solution, or if any other kind of a. So we have to make out the list that the possible ways or possible solutions to tackle this kind of a problem, to assess these kind of a problems. Once we find out these are the possible solutions, we have to select one of it and start working on it. Before getting failed or before we think that कि ये solution इस पे workout नहीं हो रहा है, हम एक solution लेंगे, उसको select करेंगे और उसके ऊपर workup करेंगे कि ये psychological issue से related patient के लिए ये किस तरह से कारगर साबित होता है या फिर मददगार साबित होता है. अगर ये अच्छा चला, इट्स वेल एंड गुड, वी विल कीप ऑन कंटिन्यूइंग. और अगर उसको इंप्लीमेंट करने के बाद अगर हमें उससे कोई कॉन्सिक्वेंसेस मिलते हैं और अगर वो वर्कअप अच्छे से नहीं हो पाता है, इट्स ऑल राइट, हम उस सॉल्यूशन को इवैल्यूएट करेंगे इन गुड वे और इन अ बैड वे आल्सो. इफ पेशेंट इज गेटिंग अ बेनिफिट बिकॉज ऑफ इट, still we will evaluate that kind of a solution, and then we use it later on also if the patient feels that kind of a symptoms in once in a while or in near future also. If patient doesn't get benefit from that solution, we will evaluate the lacking of the solution, we will work on it, and then we will present with any other kind of a solution in front of the patient. So that's how this cycle will keep on repeating for this patient. It is not just like a physical illnesses, mental illness and related to the treatment, it requires a lot of patience. And majority of the times what happens, sometimes solution works and sometimes no. So follow-up is a necessary, which is a very easier for the family physicians, so that they are in regular touch with the patients and their relatives. So follow-up is also necessary, and along with that, patient's rehabilitation. Once you know you are the family physician of any particular patient or their family members, considering their financial status, considering their emotional status, considering all the activities and their approach towards patient, towards society, and towards their future, you can understand and give the best possible solutions for the patient as well as for their relatives for the better future of the patient. This comes under the rehabilitation. So that's why there's all kind of a things, that is identifying the problem, then assessing it and implementing any possible solution on it, then evaluating that solution, taking frequent follow-up and keep on trying for the better rehabilitation of the patient, so that patient will get independent, they will get their confidence boost. Because see, what I saw in the patients who is having the mental illnesses or mental disorder, they have a extreme guilt and extreme negativity complex that society will not understand me, society will not accept me. And up to some extent, this is a very bad scenario, but yes, society is still having that kind of a stigma towards mental health, so they criticize the patient based on their illness. They don't do in cases of the physical illnesses. If the patient is having any cardiovascular disorder or any hypertension, people don't see or don't recognize a patient considering their physical illness or physical comorbid conditions. कभी हम रास्ते से जाते हुए देखते हैं कि ये देखो, ये हाइपरटेंशन वाला पेशेंट है, इसको डायबिटीज है, इससे दूर हो, इससे बात नहीं करनी चाहिए, ऐसा कभी नहीं होता. लेकिन अगर मेंटल इलनेस रिलेटेड कुछ या फिर मेंटल हेल्थ रिलेटेड कुछ डिसऑर्डर होंगे, तो पीपल विल कीप एंड डिस्टेंस और keep themselves away from those patients, keep on teasing those patients, keep on bullying those patients. So these things keeps on happening. So that's why we have to understand that कि वो स्टिग्मा रिड्यूस होने के लिए इन सारी चीजों की वजह से पेशेंट्स के दिमाग में एक इंफीरियरिटी कॉम्प्लेक्स रहता है, देयर कॉन्फिडेंस अप टू हायर एक्सटेंट इट गेट्स कॉम्प्रोमाइज्ड. So their rehabilitation is also an important and necessary. Family physicians play a wonderful role in it. Lastly, I will not take much of the time, but we'll tell the interesting facts related to the celebrity life, because I used to tell every time that not only the common people suffers from this kind of a disorder always, but the celebrity people does suffer from this kind of a disorder. You already know the example of a Deepika Padukone, who on the public platform she accepted that she was having a depression. Along with that, the Yo-Yo Honey Singh, who is a rapper and musician, singer, composer also, he was diagnosed with the bipolar mood disorder. He was in the rehabilitation center because of the drug dependence and along with that bipolar mood disorder thing. So he was under a treatment. These are the two other examples. Along with that, Mahesh Bhatt, Pooja Bhatt, both the father-daughter duo having the alcohol dependence disorder related to the personality issues, they both took treatment and they are very well now. In fact, they inaugurated one rehabilitation center in the Pune area for the de-addiction purpose also. So these all kind of a celebrity status people having or was having this kind of a psychiatric illnesses, or they went through this kind of a disorders and illnesses. So we have to destigmatize this kind of a condition. And as a family physician, as a psychiatrist, and as a true citizens of this country, we have to keep on fighting and keep on making people believe and make them aware about the psychological illnesses and for the well-being of the patient and the well-being of their family. Thank you.
Yeah. Thank you, sir, for this nice lecture. I'll request Dr. Harshila.
Thank you. Thank you, Rupa. Thank you, Dr. Sanat Pawar, sir, for giving the judgment of mental conditions. As we family physicians see all these conditions as if mental disease only, but we don't segregate them. Today, we got many ideas regarding anxiety, depression, suicidal ideations, which is an emergency situation, or only tantrums are seen in patients. Counseling a patient is also a very difficult task for us, and to take and continue their medicines in relations to mental conditions. Thank you for guiding us. Thank you again for appreciating family physicians. Now, after post-COVID, family physicians has got their previous importance, and you have appreciated it. And definitely, family physician can better judge whole family. And also we assure follow-up of a patient and rehabilitation of the patient. We family physicians will do our best. Thank you, sir. Shall we go towards question answer session, Dr.
Yes,
Rupa?
Harshila madam, question answers fast घ्या. लोक म्हणजे people are hurrying up for their clinic. So quickly go through the question answers, please.
Uh, raise hands first or
नाही, written questions आधी घ्या.
okay, okay. Some patients are very manipulative. How to
Yeah.
handle such patients? Dr. Jason has asked.
Okay. Hello, sir. So we get stuck into those kind of situations who are very much manipulative about those conditions. We have to first understand that if the patient is having that kind of a manipulative behavior, we have to get, if you are getting suspicious about that patient is manipulating the things, then we must coordinate with their family members and specifically with their parents. One or both of them will surely tell you the details related to it. Is surely the patient is a manipulative, or the personality or pattern of their communication is likewise or something else. Because majority of the patients who is having that kind of a manipulative features, they are having the personality disorder traits. Most of the patient having the bipolar borderline personality traits also, or the histrionic personality traits also. So these kind of a cluster B traits we used to call them. So these are having the manipulative patients. We have to tackle them very smartly by asking the information related to them, to their close ones, either to their mother or father, or or their wife, or sometimes interestingly their own children. Though they are very small, up to after 6 to 7 years of age, you can ask them the details related to the patient. They will beautifully tell you what is exact pinpoint which is bothering, or which
Yes,
is
yes. Thank you, sir.
Dr. Jayashree Sonis has asked, cause of anxiety are thoughts. How to manage thoughts?
Cause of anxiety, most commonly it occurs due to the previous experiences, previous bitter experiences. Sometimes it commons. There are 3 to 4 causes behind it. One is the biological, that is sometimes it is a genetic, but it's not clearly proven yet. But up to some extent, yeah, the genetic or a hereditary cause contributes into it. Second one important is their personal experiences or past experiences related to the anxious issues or traumatic incidences. If they face any kind of accident, or if they saw any kind of a bloody exposure, or any kind of traumatic incidences, scenarios, any conflictual situations, that impacts the most on their mindset, so that anxiety gets triggered out. So that's how it goes. And if we have to manage their anxiety, there are multiple ways to manage it. First, we have to find out up to what extent their anxiety persists, and after getting into which kind of a scenario their anxiety triggers the most. So that first we have to kind of a scenario up to certain time. Then we can use a medication. There are n number of medications, that is SSRI, selective serotonin reuptake inhibitors, which we can use. Better to avoid flunil, that is fluoxetine. Better you can use sertraline, or we can use escitalopram like medications for the anxiety relief or other anxiety reduction. Benzodiazepines, I think, should not used for the anxiety purpose if the patient is having only anxiety issues, because benzodiazepine gives the sedation, so that sedation again will compromise their daily routine. So that if the patient is having anxiety as well as the sleep issues, then yeah, you can give benzodiazepines for those kind of a patients, but make sure you should give it into the night. Or if you want to give it into daytime, like an etizolam or alprazolam, make it into a half tablet or very small dose, that is 0.25 milligram or up to maximum 0.5 milligram, so that their daily activity will not hamper. But better I will prefer that SNRI and SSRIs, so that their anxiety will reduce.
Thank you, sir. Dr. Prerna Barve has asked why guilt is more seen in females and why some people feel more guilty.
Yeah, this is another one interesting scenario. Why the people feels guilty? Because guilt occurs because of breaking those things which is not acceptable into the society. This is what exactly happens with the guilt. सोसाइटल नॉर्म्स के हिसाब से जो चीजें नहीं करनी चाहिए अगर वो हम करने लगते हैं, या फिर जो चीजें डिसेंट नहीं मानी गई है उसे अगर हम करते हैं, तो उससे रिलेटेड क्विकली गिल्ट मन में पैदा हो जाता है. दिस इज वेरी इंटरेस्टिंग और ब्यूटीफुल सिनेरियो. So that's how guilt develops into the mind. And majority of the times what happens in our society also, there are this is sadly we can say this is approximately a male dominant society, so there are a lot of restrictions on female women. So if they try to come out of it or doing a small things, that also creates an very much of a guilt. क्योंकि हमारे यहाँ पे सोसाइटी में मोस्ट ऑफ द टाइम ऐसा हुआ है कि फीमेल्स के लिए और मेल्स के लिए एक अलग सिनारियो या फिर अलग प्रोस्पेक्ट डिसाइड किया गया है फ्रॉम सोशल नॉर्म्स और सोशल पॉइंट ऑफ व्यू. If a male person or if a James does that an activity in a normal or usual way, this is not this will not a point of a discussion for all of us. But if any kind of a female does that kind of a activity, then surely this will be a point of a discussion in a good way, in a bad way also. Considering with the orthodox nature or with the traditional views or point of views, so this thing comes up very gradually and suddenly or like quickly. So in the females, this is things related to the guilt happens most commonly about this kind of scenario, because social structure was designed since very prolonged period of a time, so that if a woman is a path changer, game changer or path breaker, then this will not considered as an usual scenario. औरत होके या फिर लड़की होके इस तरह से काम किया, either in a good way or a bad way, that will create kind of a guilt into the person who is doing things or who is suffering from that also. So to avoid that kind of a guilt, better you should take a counseling for that, so that you will use to express things in front of a person who mostly neutral towards you, who will see things happening in your life in a neutral way or in a third position, so that you will able to express it in a proper way or in a frankly behavior, so that you will get to know a better idea about yourself, about your own life making decisions, so that they will use to say or use to present an opinion in front of you, and you will get more often convinced, or if not convinced, you will get a clear idea about it, and that ultimately helps to reduction of the guilt.
Okay, thank you, sir.
Sanat sir, my small request, we will have to do little fast forward of question answers, rapid fire type karayla lagel, because there I can see lot many questions are there. So I don't know how much time you also will be able to give, because so thoda sa rapid fire sarkha karuyat ka.
ओके शुअर तुम्ही क्वेश्चन पद्धतीने मला हे सांगा, मग मी
Yes.
मध्ये जात नाही.
Sir, basic pharmacological treatment for anxiety and depression. Has asked.
Okay, basic pharmacological anxiety and depression साठी SSRI and SNRI both are available. We have a great factor that SSRI and SNRI both works on the anxiety and depression actually or simultaneously. So we can give both of it. For a particular anxiety, along with the SSRI or SNRI, we can use the benzodiazepines as well, which will reduce anxiety up to the majority of extent. And if the patient is having the suicidal ideations or having the negative thoughts or increasing over racing of thoughts, then we can use a small dose of the antipsychotic or D2 blockers in the form of the risperidone or olanzapine. Very small dosage like 0.5 milligram or olanzapine in the form of 1.25 milligram. If you have access for those kind of a medication, you can surely introduce it. But most of the time, I will just observe avoid additional view of SNRI.
Is exercise help in mental illness?
Yoga and meditation, yes,
Sir has asked.
that helps. But sir, the funny part is that in some patients, I saw that by starting doing yoga and exercise, their cycle or thought, their thinking pattern, it went on racing mode. कुछ पेशेंट्स ने बोला कि योगा करने के बाद मेरा थिंकिंग प्रोसेस बहुत ज्यादा ही बढ़ गया, मेरे ख्याल मेरे कंट्रोल के बिल्कुल ही बाहर जा रहे हैं, तो मैंने योगा और मेडिटेशन बंद कर दिया. So in both ways, but I will suggest that yoga and meditation, yes, it does help. But first start with treatment. Once you get stabilized, you can move to the lifestyle mechanism and you can follow the yoga and meditation part. Also, you can do regular routine exercises and activities. But one thing, post-COVID scenario is getting changed. We are seeing a lot of cases happening with the cardiovascular disorder. This happens because of the thing you all know that, but still, this is my duty to tell you that majority of people are getting conscious, are more about the health, and they were not used to do routine the gym activities, but suddenly they are starting doing things like lifting weight and all those things. Ultimately effects on the and appropriate exercise with the help of a good trainer and under the help of a physician, that will surely.
Sir, combination question I'm asking. What is a common drug for anti-anxiety and antidepressant as a GP or family physician? And can anxiety cause depression? And how long it should be continued at GP level?
Well, you will get access for the medications like an escitalopram, along with that venlafaxine or desvenlafaxine. So yes, you escitalopram, escitalopram in single molecule as well as in the combination, that escitalopram with the clonazepam, which is also an you can use it in any extended form, and it is a very good medication. It ultimately, apart can use also, but it has a sedative effect, so better it be used in the night time. And apart from that, a newly launched molecule vertioxetine, that also helps in to keep them out of the depressive state. And in the part, also and if you have to give it patient in the daytime, make the dose half of it so that patient will not get sedated easily. So these kind of medications you can use. Anxiety or depression, patient comes to you with the depressive or anxiety features with the history of past 3 to 4 months or past couple of days, but not only the one single day or 2 day. Depressive history must be having 3 to 4 months or more than that. So that treatment for that, it requires up to 6 to 8 months of a duration, and then you can taper the dosage. If you are starting escitalopram dose with the 5 milligram, then if the patient is getting a partial response from it, increase the dose up to the 10 milligram, or then increase to dose up to the 15 or maximum up to 20 milligram. But if the patient is feeling well or is doing all this activity and no as such a significant or a serious event related to the anxiety or depression for up to at least 3 to 4 months, then you can think of reducing the dosage. Means from 20 to 15 milligram. If patient keeps on doing well things for next 2 to 3 months, then again you can reduce it to the 10 milligram. And after 2 to 3 months, if the things go on well, then again 5 milligram. And then once in a while, you can omit the dosage or omit the treatment and then observe for the patient. But keep on observing the patient, whether the patient develops the symptoms again and again or not. This is how the pattern of a treatment goes.
Okay. Dr. Hingorani has asked how to help the affected person with anxiety, depression, who doesn't wish to go to doctor for treatment.
It's all right if the patient is not comfortable to going towards doctor, then no issues. Keep on counseling with the patient up to certain extent. Keep on explaining them. Observe the severity of the symptom. If the symptoms are not that much severe, then it's okay to give them counseling. If the symptoms are that much severe, which are compromising their daily routine, their interpersonal relationship, and they are hampering them most, then ask them to go to the specialist or the psychiatrist for the further treatment. Or if even after that, if patient is not willing to do so, keep on counseling the patient in any way. And in between that, you can just give them hint or give them one pinpoint input or briefing about that. Once in a while, think of going towards the psychiatrist. So keep on telling them in between your discussion, not more frequently, but once or twice in that discussion, so that patient will have an idea throughout their mind that whether or this will be a mind that whether go to the psychiatrist or not, but the option is still available.
Okay, thank you, sir. Dr. Bhandwalkar has asked, explain more about mania and its treatment.
Okay, mania, it generally occurs in both the cases. In the cases of the psychotic illness, or we can say psychotic disorder, and also the patient is having the bipolar mood disorder type 1. There are two types of it. But type 1 is more prominent with the mania. The patients having the presents with the symptoms of the mania is having the big talks, excessive expenditure tendency, that is they spends a lot of money up to lakhs or crores also. We have seen those kind of a patient. Reduced need for a sleep, excessive engaging into the multiple activities, excessive investment, increase the food intake, increase the substance consumption or alcohol consumption, rash and reckless driving. These all kind of things. Also, uh, get they don't want to get interrupted in between their communication. They will speak continuously and for more number of times, and excessive talk, and mood is always on high elevated, and they also presents with the symptoms of a mere restlessness, these kind of a symptom. So better if patient comes to you with the manic feature, use benzodiazepine in the form of a higher dosage, considering the age and the weight of the patient. If the patient is more getting violent or aggressive, we can use an antipsychotic in the form of injectables, that is a haloperidol, along with that promethazine combination, either a 525 milligram or a 1050 milligram in that combination. Give the injectables intramuscularly. We have that kind of a guideline so that you will get to know that injectables should be given to the patients having symptoms of the mania, so that patient will calm down, relax. These medications are not only for the calming down the patients or to give the sedation also patient, but the patient, the injectables having the dosage of the haloperidol, which is itself as an antipsychotic, it will also reduce the racing thought of the patient, because the mania comes out of because of the racing thought or uncontrolled thoughts, excessive dopamine secretion. That's why it comes. So these kind of injectables, first and foremost thing you can give to the patient. If required, you can restrain the patient, but with the consent of the family members, and be taking proper precautions and their written consent. Then you can restrain, and if required, you can give the injectables to the patient. And after the injectables, approximately, if you have that kind of medications, you can give the quetiapine 25 or 50 milligram, likewise the dosage on the benzodiazepines. And if even after that patient is not manageable, you can send it to the higher centers, or if any proper psychiatric setup.
Okay, thank you, sir. Dr. Sarika Bhujbal has asked, please guide on derealization problem.
Okay. Derealization in what context? About the insight of the illness realization?
Nothing has asked more. Only derealization problem.
Okay. Because this comes under
Not real.
pardon?
तो स्वप्नात आहे असं रुग्णाला तो स्वप्नात आहे असं वाटतं जे काही सत्य
patient ला काय
झालेलं आहे आता ते स्वप्नात
काय काय
आहे स्वप्नात
स्वप्नात आहे
त्यांचा
असं वाटतं. पेशंटला स्वप्नात आहे असं वाटतं.
ओके. रिअलायझेशन म्हणजे जवळपास आपण त्याला लॅक ऑफ इन्साइट असं म्हणू शकतो. So, derealization case mostly happens the patients having the psychotic illness in the manic feature also, but it is very much less common into the cases of the anxiety disorder or the depressive disorder, because depression and anxiety मध्ये patients ला usually realization असतं की something is going bad किंवा something is going against their normal life. So most of the times त्या symptomsच्या वेळेला patientचा derealization mode हा इतका नसतो. पण considering the psychotic illnesses, there are higher chances that patient develops a derealization. अशा वेळेला जर ऍक्टिव्ह सिम्पटम्स आहेत का हे थोडंसं इव्हॅल्युएट करून पाहावं लागेल आपल्याला, आणि जर असेल तर त्यामध्ये पेशंटला बॉदर करण्यामध्ये किंवा त्याच्यामध्ये पेशंटचं काउन्सिलिंग करण्यामध्ये अर्थ नाही. फर्स्ट अँड फॉरमोस्ट thing which we have to do, give them immediate treatment. ट्रीटमेंटने ज्या वेळेला सिम्पटम रिडक्शन होईल त्याच्यानंतर ते सिम्पटम रिडक्शन अप टू किती एक्सटेंट पर्यंत झालंय ते बघून त्याच्यानंतर आपण काउन्सिलिंग स्टार्ट करणं हे बेटर राहील आणि त्यांना डिरियलायझेशन मोडमधून बाहेर काढण्यासाठी रिएलिटी चेक ज्याला आपण म्हणतो त्या पद्धतीनं त्यांचं काउन्सिलिंग करणं हे इम्पॉर्टंट राहील की मेक देम अंडरस्टँड और मेक देम फील दॅट व्हॉट दे आर ऍक्च्युअली फीलिंग or the thinking is not realistic or not related to the real environment or real things as well. So हे आपल्याला ग्रॅज्युअली करावं लागेल पण कुठलीही काउन्सिलिंग किंवा कुठलीही गोष्ट सायकोटिक इलनेस कन्सिडरिंग द सायकोटिक इलनेस नॉट रिलेटेड टू द एंजाइटी और डिप्रेशन बट कन्सिडरिंग द सायकोटिक इलनेस और मॅनिया और सिव्हिअर डिप्रेसिव्ह डिसऑर्डर या केसेस मध्ये काउन्सिलिंग शुड गेट सेकंड प्रेफरन्स. फर्स्ट वी हॅव टू ट्रीट द पेशंट. सिम्पटम रिडक्शन केल्याशिवाय तुमच्या काउन्सिलिंगला अर्थ राहणार नाही कारण ते मग दगडावर डोका पडल्यासारखं होईल त्याच्यातून फक्त थोड्या वेळासाठी पेशंट ऐकल्यासारखं होईल कारण ऑलरेडी एन नंबर ऑफ थॉट्स त्याच्या डोक्यामध्ये चालू आहेत त्याच्यात तुमचा एक ऍड होईल इतकंच आणि त्या चक्रामध्ये तो विरघळून कुठल्या कुठे जाईल त्याचा पत्ताही लागेल.
Okay. Dr. Madhurima Kulkarni has asked, patient having age 27 years, newly married, suddenly having sleep disturbances, taking less food, and main thing is no communication with parents. Is there any manipulation by patient?
We have to find out that it seems like after listening to this, it's related to the mild depressive features. But what are the triggering factors related to it? We have to find out. Second thing is that this behavior of the patient is common in front of the family members also, or in the absence of them also. If in both the cases the behavior is the same or congruent, then definitely we can go towards any kind of a psychological issues. And if not, if it does those things only in the presence of the family, how we will rule out those things? If is a lack of food and there is a reduced need for sleep, it ultimately sees on the face, their approach, their behavior, their tone of a talking, or their way of a communication. So we can rule out these things by asking the other things also. How do you work? म्हणजे तुम्ही काम कसं करता किंवा कामाच्या ठिकाणी तुमचं मन लागतं का, लक्ष लागतं का, एनर्जी असल्यासारखी वाटते का, परफॉर्मन्स कसा आहे त्यांचा कामाच्या ठिकाणी, त्यांच्या बॉस कडून त्यांना अप्रिसिएशन मिळतं का किंवा तिथे प्रॉब्लेम्स येत आहेत का, तिथे त्यांच्या कामाबद्दलचं काही डिसअपॉइंटमेंट आहे का, या गोष्टी आपल्याला रूल आउट करता येऊ शकतात. सोबत फॅमिली मेंबर्स किती आहेत, प्रत्येकासोबतचं कम्युनिकेशन कसं आहे आणि प्रत्येकाच्या सोबतचं असणारं कम्युनिकेशन, वे ऑफ एक्सप्रेसिंग थिंग्स सेम आहे की तिन्हीमध्ये काही व्हेरिएशन्स आहेत, व्हरायटी आहे, ह्या गोष्टींबद्दल थोडंसं तुम्हाला डिटेलमध्ये जाऊन डिस्कस करावं लागेल. अँड यू विल अल्टिमेटली फाइंड the exact scenario whether the patient is malingering or the patient is having the exact psychological disorder.
Okay, thank you, sir. Dr. Abhinav Gupta has asked how to manage social media related depression.
Okay, media related depression you have to manage by doing by monitoring the screen time of the patient first. Is there, we have to check out that whether there is what is the exact need of seeing the social media, because some of the patients, some of the people earn money from the social media use or doing activities on the social media. Some majority of the people will not engage into it for the earning money, but just for relaxing or just for the checking things. So we have to observe those things also. Positive factors for that we have to rule out. This is the one thing. Secondly, social media disappointment is happening into the patient, that not getting enough likes or enough views or enough comments because of it, or not reaching up to more number of people. If that thing is happening, we have to monitor and reduce the screen time of the patient and engage them into the more constructive activities. We have to find out what is the personality, nature, and past hobbies related to the patient. If the patient might be having any reading, painting, or wandering into the here and there, or playing any kind of a music, that kind of a habit patient is used to have in his prior days, but nowadays because of the presence of a social media, patient is gradually reducing or stop doing those kind of activities. We have to keep it out of that things from the past, and we have to re-engage or reintroduce the patient to these kind of constructive hobbies, so that the patient's screen time will reduce automatically. हम पेशेंट्स को डायरेक्टली मोबाइल यूज करना बंद कर दो या फिर मोबाइल का ज्यादा इस्तेमाल हो रहा है, इस तरह से अगर हम बताने जाएंगे Absolutely, patient will deny it and will not stop using those mobile. इनडायरेक्ट कम्युनिकेशन से इनडायरेक्ट अप्रोच यूज करके धीरे धीरे उनका स्क्रीन टाइम हमें कम करना पड़ेगा एंड इन
Thank you
बिटवीन
so much,
दैट
sir. But I have wanted to elaborate on the question. What you're saying is absolutely right. I work with a lot of IT professionals. So their major concern is that everybody is having a very nice life. They are going on holidays, they are partying, they're having fancy clothes. And and I'm talking about people who are absolutely comfortable in life, having a good job, good family life. Still, they go into depression just because they're comparing themselves with other people on social media. That is a very major issue these days.
yeah,
How to handle
absolutely.
that?
Yeah, this is a very common scenario. What I was said in the lecture, that is a changing lifestyle. People are living for the money. Money is for a living that people has completely forgotten. So people are living for the money, and the money demands, and along with that changing lifestyle, that I need good clothes, then social drinking, visiting the various kind of restaurants, going into the fancy places, it will require a lot of money, and so that's why I have to earn a lot, and that's why people are compromising their physical as well as a mental health. People are thinking of earning money in a very short period of a time. Most of the IT professional, you are seeing a lot of people, they might have that kind of approach that I will earn money up to the age of 40 or 50 age, and then I will retire, and then I will spend the rest of the life very happily. Yeah, that is a good scenario, and this is a very good description of living a life, but it's very good for listening only. What you are doing in these 20 years is you are wasting or you are compromising your health up to very much extent. अगर ये 20 साल में आप अपने मेंटल एंड एज वेल एज फिजिकल हेल्थ को इतने लेवल तक स्ट्रेच करके जा रहे हो कि अगले 30 सालों में आपको सिर्फ उसको रिकंस्ट्रक्ट करने के लिए या फिर उसको रीइंट्रोड्यूस करने के लिए, उसको अच्छे से बनाने के लिए बाकी के 30 साल आपको अगर गंवाने हैं, then there is no use. People are in hurry to getting money or earning money. So this is not appropriate.
Okay,
People
thank you, sir.
should get think, should get break in between their work. आपको अगर 8 से 12 घंटे का काम दिया है, तो इसके बीच में आप 1 घंटे के बीच में कंटिन्यूस स्क्रीन एक्सपोजर अगर आपको होता है, तो आप बीच में 5 से 10 मिनट का गैप ले सकते हो. Rather than doing this, people are getting engaged into the mobile phones whenever they get free time from their laptops. So again, you are yourself into the different kind of a screen. So that is not required. If you are exposing continuously to the laptop, which is related to your work and your bread and butter, it's okay, but take gap in between it, so that if you close your eyes, being rest, being calm, and keeps on sitting or keeps on lying on the place where you are working for at least 5 minutes or 10 minutes, that will definitely help to boost your memory, to give rest and relaxation period for your brain, and then you can re-engage into the activities. That will help.
Okay. Are there any suggestions on prevention of such elements like anxiety, depression?
Yeah, there are. Just 1 second. Yes, madam. What you were saying?
Suggestions on prevention of such elements like anxiety and depression, which is becoming very common now.
See, there are, rather than prevention strategies, we can call it as a healthy lifestyle mechanisms. There are ways of coping or dealing with those kind of scenarios. That is, first and most thing, make fix your priorities. For earning well and stabilizing your house, stabilizing for your family, investing for your children's future, that's all will be okay. But you have to do your job profile for a fixed duration of a somebody is having this shifting job hours, then it's okay. No problem at all. But even after that, you have to do work for certain period of a time, then take a rest, spend some good quality time with your family members for at least 2 hours. Engage yourself with the family members. I see we all see, all our family is also in the home also, that even after getting some time, everybody is getting engaged into the mobile phones and seeing those things, and randomly they're scrolling down and scrolling upwards things, and they spend a lot of time in doing those things. Better you should chit chat or talk among your family members. Spend some quality time with the friends. Go for just sit down, relax, chat, but make open communication with each other. Apart from one most important thing I want to tell everybody, that take out at least some time, at least half an hour for only yourself and not for the family, not for the work, not for anybody. At least half an hour only for yourself in whole 24 hours. In that half an hour, in that 30 minutes, either you can sleep peacefully. Not I'm just saying that sleeping for the 8 to 9 hours. Just lie down, keep your eyes closed, and just be relaxed. Apart from that, you can do in that 30 minutes, read your favorite book, you can listen your favorite song, or you can do nothing. Don't do it.
Okay.
Be relaxed, comfortable. Might be, I will suggest a good option. Be isolated for 30 minutes. Don't do it. Don't think of anything. Just let it be. It will surely boost you, surely come to you. It will make you relax. And then again, you will start engaging your family members, having dinner with them, having chit chat with them. Once in a while, you can take out time for bringing them into the good atmosphere, good places nearby, not to the extreme places or not each other. If possible, you can surely go, but that you can do. Spending time to watching good together, not on the mobile phones. Again, that's one thing. Because going into the theater and watching cinema, this is a kind of a process. But you shift from one place to another place, that will certainly refresh your things. Seeing good, listening to the good music, reading any kind of a book, or making any kind of a good food at home, that is also a different scenario. So these kind of activities will surely freshen up and will give boost to you, encourage or engage into any kind of activity. You can tell these kind of solutions to your patients as well.
Uh,
Dr. Harshita, can we take just one question last?
last question only. Sir,
Uh-huh.
tips for caregivers of such patients in their family so that they can handle the situation well.
The first thing which we have to understand, a very good questions the madam has asked. That is we always tell the patients relative about the caregiver's burden. The patient is having anxiety, depression, along with that other psychotic illnesses. They have a tremendous kind of a caregiver's burden on their own, and there are higher chances that caregivers themselves develop the symptoms or features related to the depressive features, somatic complaints, and anxiety features. If anybody is their old age relatives or parents at their home, and one of the members is having prone towards taking care of those family members, and they compromise their own lifestyle, they compromise their daily schedule, they compromise their health up to majority of the extent while taking care of those aged ones at their home, and gradually they start developing another kind of a psychological illnesses or problems related to the anxiety, depression, multiple somatic complaints or somatoform disorders likewise, and depressive features. So for caregivers, my suggestion will be that the caregivers burden we have to reduce that, so that for the caregivers, first thing, their own mental health is very much important, so they have to take care about their own mental health. They can shift their responsibility to another person at home for quite a period of a time, so that they will get to introduce into the outer environment, and they will get to move freely outer surroundings, so that they will relieve the responsibility of taking care of the other people. First thing. Second one, they can support to the patients who is having the anxiety or depressive features by communicating with them, counseling with them. I know this might get irritable, or this might get a frustrating scenario, because this is a prolonged scenario of counseling the patients and helping them. But in between time, you can take a break from that kind of activity so that you will get new energy or the regeneration of the energy, so that you will counsel the patient about their medications, counsel the patient about the necessity of the treatment, and keeping the good points or keeping the positive point of view of the patients in front of the patients, and healthy communication with the patient, rather than making them realize about their illnesses, that is they are ill, they are having anxiety. Make them sure or make them encouraged to do activities which they don't used to do previously, or they were hesitant while doing that kind of activity. More supportive towards those kind of activity. So this kind of things or this kind of ways will help the caregivers to take better care of the patients.
Okay. Thank you, sir. Thank you for patiently explaining and answering all the questions. Thank you, MCF and Dr. Prakash Mahajan, sir, and Dr. Rupa Agarwal for giving me opportunity to connect with you all. I hand over the charge to Dr. Mahajan, sir. Thank you.
Mahajan sir.
I think he's unable to unmute.
Sorry. Mahajan sir. Okay. So here I think Mahajan sir join आहे, पण बहुतेक काही गडबड असेल. So thank you so much, Dr. Sanat. It has been such a wonderful session. I don't think I'll be able to, I'm capable enough to summarize in short whatever so many important tips, important carry home messages that you have given to our audience. And it has been, many people have already mentioned in the chat and as well as on YouTube that they have really liked the session. So thank you so much for being part of this platform today. It has been an honor for us to have you. Like from the time when Dr. Parlikar suggested your name, that itself says, like, it defined your caliber, how good public orator and someone who can connect the private practitioners' medical practice to social work background. So you definitely proved that thing through your talk. So thank you for this. And to the participants, my request is that this June, we are planning to hold a medical conference for our general practitioners. So we will be posting the details about the same soon. And like always, we will expect our participants to register for the conference and participate in the conference, because this conference that we are holding is mainly as a fundraising activity for this mental health helpline. The way sir has mentioned lot many tips where we general practitioners can refer or make use of this mental health helpline for our patients. So to run this helpline successfully, finally, finance is a very important thing. And to generate funds, we are going to have this conference. So more details about the conference we'll be posting on the groups in a day or so. And I know it's already late. Thank you all of us for being with us for this late time. Session सुरू होऊन बराच वेळ झालेला. So once again, thank you everyone. Thank you Harshila, Dr. Prerna, Jayashree, and thanks to MCF. Have a great evening.
Thank you.
Thank you, sir. So we will end the meeting.
And end from our side.
Yes, sir. Yes, sir.
Okay. Thank you.
Thank you so much.